Good morning. Today I'm going to discuss with you pre-transplant dialysis. I'm going to discuss this topic under the following sectors. I'll start with introduction, then how to evaluate the patient for transplantation, because we shouldn't forget the patients who are maintained on dialysis need transplantation. We shouldn't forget this. Dialysis modality and its impact on transplantation. And in this sector, I'll show some data about peritoneal dialysis or hemodialysis and the impact of these modalities on transplant outcome. And then I'll discuss the issue of duration of dialysis on transplantation outcome. And then the preemptive transplantation. Preemptive transplantation means proceeding for transplantation without dialysis, and then special issues, and I'll end with some guidelines. Let us start with questions. For each statement, I need you to just to say if the statement is right or false, true or false. Dialysis should be done within 24 hours of renal transplantation. True. The discontinuing ACE inhibitors before surgery is recommended.
False.
Prolonged fasting before transplantation is associated with hypoglycemia and hypokalemia.
True.
Post-transplant weight gain is more frequent if the patient is on peritoneal dialysis program.
True.
Post-transplant vesico-ureteric reflux is positively correlated with the duration of dialysis.
True.
Post-transplant thyroid cancer is less common if dialysis duration is more than 5 years.
True.
Preemptive transplantation is associated with more frequent post-transplant hypophosphatemia.
True.
Preemptive transplantation after graft failure for the second transplant is associated with less favorable outcome.
False.
iChoose is used for predicting the outcome after transplantation.
True.
So from your answer, I think this presentation is important because I'm sure that you change your answer at the end, because I'll repeat the question at the end of my presentation. For introduction, if you want to know the principles of preparing the patient on dialysis for surgery, I recommend you to read these two subjects on the up-to-date: medical management of the dialysis patient undergoing surgery and anesthesia for the patient on dialysis. So I recommend these two chapters within up-to-date. Let me to start the general approach for doing surgery for the patient on dialysis by us answering these questions. What are the indications for doing dialysis before surgery?
Yeah, if the patient is hyperkalemic, overloaded, ABG is acidotic.
So generally, if the patient is maintained on regular dialysis and he is dialyzed adequately, the patient will be stable. So if the patient is dialyzed 3 times per week and we are planning for elective surgery, it is better to plan the surgery. For example, if the patient is dialyzed on Sunday, Tuesday, Thursday, it's better to do the surgery on Monday, so long as he is dialyzed on Sunday. This means that we prepare the patient for surgery by doing dialysis on the day before surgery. That's true in general, but at the end of these questions, I'll show you that in transplantation the issue is a little bit different. Again, we don't like our patients on dialysis to go for surgery while they are hyperkalemic or overloaded or acidotic, because these points carry a poor prognosis. Do we need any intensification? If the patient is supported by regular hemodialysis or peritoneal dialysis and you want to proceed for surgery, is it mandatory to intensify dialysis before surgery?
Maybe yes, maybe needed.
For hemodialysis or peritoneal dialysis? Or you don't know?
I don't know.
Yes, for hemodialysis, there is no need to intensify hemodialysis so long as the patient is adequately dialyzed. And we don't add any or supplement dialysis session except if there is critical indication for doing that. As we mentioned in the first question, hyperkalemia, acidosis, and overload. But for peritoneal dialysis patients, it's better to intensify peritoneal dialysis for 1 week before elective surgery. Do you know why? Because we are afraid after surgery that we cannot resume BD immediately. So it's better to do better peritoneal dialysis. Secondly, peritoneal dialysis is not best fitting for hypercatabolic state and for surgical state. So it's better to increase the frequency and duration of peritoneal dialysis for 1 week before surgery. Okay? Do we discontinue certain medication and why? If you remember, the question was on ACE inhibitor. Should you discontinue ACE inhibitor before any surgery?
Yes, it may
Why?
affect the hemodynamics also.
Because we shouldn't forget that the patient on surgery will be subjected to anesthetic agents. Anesthetic drug may lead to vasodilatation. And if we use drugs like ACE inhibitors, ACE inhibitor may increase this effect that may lead to some problem, hypotension and ischemia of the organs. So it's better to discontinue ACE inhibitors or angiotensin receptor blocker before surgery in general. And and other drugs like diuretics, because we are afraid of hypotension after anesthesia. So it's better to stop IV diuretics and ACE inhibitor before the surgery. A baseline laboratory set. Do we do this check before surgery? Is it recommended?
Yes.
Yes, it's recommended to know the status of potassium, blood gases, electrolytes, is to be sure that the patient is balanced. What is the expected hemoglobin level for doing surgery for patients on dialysis, so long as the surgery is elective? It is the same like the recommended levels in general for dialysis patients. We should take care of vascular access to avoid compression of the vascular access or giving injection within the vascular access. So we should be careful about vascular access. Regarding the issue of fasting, if you remember, there was a questions about fasting and hypokalemia. Fasting, prolonged fasting for hemodialysis patients precipitate hypoglycemia, because the patients on dialysis are more prone to hypoglycemia, and this will lead to insulin switch off that may lead to distributional hyperkalemia. So it is hypoglycemia and hyperkalemia. Hyperkalemia may be fatal, leading to arrhythmias and catastrophic events. So this is why we don't like to allow patients on dialysis for prolonged fasting. Even if they are allocated to the night shift of the surgery, we should give them fluids, including glucose, or avoiding the prolonged fasting. Regarding when should we do dialysis before surgery? In general, dialysis should be done within 24 hours of any surgery. But in transplantation, it's not mandatory. Why? Why it's not mandatory to do dialysis within 24 hours of transplantation surgery, renal transplantation surgery?
Because the kidney will regain its function.
So for preparing the patient for transplantation, it is better not to aggressively ultrafiltrate the patient, because it may lead to dehydration and delay diuresis. So it's better to, yes, we want the patient eovolemic, but we shouldn't allow drastic reduction of dry body weight, because this may lead to increasing the risk of the graft dysfunction. And this is one of the articles showing that dialysis within 24 hours of transplant doesn't improve graft function, and sometimes it may be associated with problems for the graft function. But we should be careful, because we don't allow transplantation for hyperkalemic and acidotic patients and clinically manifest hypervolemic patients. So long as the patient appearing eovolemic or little bit above the dry body weight by half kilogram or something like that, it's fine, because it will help the diuresis. But we don't like to do anesthesia while the patient is hyperkalemic or acidotic. So long as the patient is not hyperkalemic, not acidotic, we don't like to do dialysis within 24 hours as routine. So the patient should be within his routine of dialysis, and then the transplantation done. Regarding the appropriateness for transplantation, it's very important. And here I wanted to take this quotation from Professor Ahmad Shukr presentation on Tanta on November 15th this month. When he brought this slide, principles to identify the indications and the contraindications for kidney transplantation. If you look here, the word indications is written very small. Do you know any meaning for this?
That all patients are indicated.
This means that we shouldn't discuss the issue of indication. We should discuss the issue of contraindication. So we shouldn't forget the issue of transplantation, because transplantation is the best renal replacement therapy modality. So we should assess our patients on hemodialysis for transplantation appropriateness. We should search for contraindication. And if there is no contraindications, the patient is suitable for transplantation, and we should encourage transplantation if there is a donor. And this is why therefore there is a need for a workup process to determine suitability for kidney transplantation. Why renal transplantation is the best renal replacement therapy modality? Because as you see here, the renal transplantation is associated with the superior survival in comparison to hemodialysis. And here, this is the survival of the general population. In comparison to the general population, you'll find the survival for transplantation and for dialysis. If you look here, for the different age ranges, irrespective to the age ranges, transplantation, which is green color, is witnessing better survival in comparison to dialysis. So again, renal transplantation is the best because it saves life. And this data shows as well renal transplantation is less costly. So the less cost and with prolonged survival. To address the issue of prediction, the fitness for transplantation, this is one of the scores that can be applied for elderly. Here, you can look at the different demographic criteria of the patients, and for each demographic criteria, you'll find here score points. And this another other criteria, and you'll find here a score point. At the end, if the score is within category 1 and 2, this means the score is either less or equal -9 or up to -4, this patient is suitable for transplantation. Because 5-year mortality for these patients is less with transplantation. But if the score is higher than this, for category 3 and 4, 5-year mortality is very high. That doesn't justify doing a transplantation. So this is one of the scores that can be used. Another score is the frailty score. The frailty score is very simple score. Here, we can ask the patient these questions. Are you fatigued? And the patient will answer yes or no. If yes, the patient will be afforded 1, score 1. Resistance, are you unable to climb stairs? The unable, if yes, 1. No, 0. Are you unable to walk 1 block? If he is unable, 1. If he is able, 0. Do you have more than 5 illnesses as comorbidity? If yes, 1. No, 0. Losing weight, have you lost 5% of your weight in the last 6 to 12 months? If the answer is yes, 1. No, 0. Here, the total score will be 5. If the score is 4 to 5, this is frailty. And this patient will not be suitable for transplantation. Then the intermediate is 3 to 2, and less than 2 is no frailty or little bit no frailty. If there is no frailty, we can proceed for transplantation. And this is another score that can be followed. I want to ask you a question here. If we are dealing with highly sensitized patients, this means that the patient has high level of donor-specific antibody. Is it better to go ahead for desensitization and transplantation or to wait on dialysis? What's your opinion?
I think to go for desensitization.
Based on what?
That is incompatible, HLA incompatible.
No, why you selected desensitization then proceeding for transplantation? I think your answer is based on the study that was published in New England Journal of Medicine showing that survival for this is the straightforward case for transplantation. This is the waiting list. This is the patient who will be desensitized and this patient who will be left on dialysis. So the patient here is kept on dialysis. Here, desensitized. Here, the survival for desensitized patients is superior than patients who are kept on dialysis. This paper paved the way for answering yes, we should desensitize the patients if we have the facilities and proceed for transplantation. But early this year, this is the UK data showing that for HLA incompatible kidney transplantation in UK confers no greater risk to patient survival than awaiting compatible living or deceased donor alternatives, but doesn't confer a survival benefit either. What this data? What is the value of this data? This means that if we don't have facilities for desensitization, yes, we have here supporting evidence for keeping the patient on dialysis until the patient finds a suitable donor. Because you shouldn't forget that desensitization is very expensive and be associated with infection and malignancy on the long run. So again, this is supportive data for keeping on dialysis. So the issue of highly sensitized patient to do transplantation or to keep the patient on dialysis is a debatable issue. And nowadays we have the supporting data for keeping the patient on dialysis from the UK data. Regarding dialysis modality, the question is, if the patient is dialyzed by peritoneal or hemodialysis, is this modality having any effect or impact on transplantation outcome? If I ask you, if we are addressing patient survival, which will be the best, BD or HD? Transplantation after peritoneal or hemodialysis?
I think after hemodialysis.
So this is a review showing that survival after BD is better, but you can find some articles showing the reverse. But this is a review and it is the data. So survival after BD is superior than hemodialysis. Graft survival?
I think after hemodialysis.
The better effect on BD than hemodialysis. Delayed function graft?
After BD.
Less frequent after BD, because in the hemodynamics of hemodialysis may precipitate this issue. Vascular thrombosis, is it more common after peritoneal dialysis or hemodialysis?
More common in BD.
Why? Do you know why?
Affected vessel.
Yes, the vascular thrombosis is more frequent after peritoneal dialysis because in peritoneal dialysis there is increasing leakage of albumin within dialysis, and this increases thrombogenicity. So this is why the vascular thrombosis is more frequent after peritoneal dialysis, because of the tendency for more hypoalbuminemia or albumin leakage during BD. Post-transplant diabetes,
hemodialysis.
it is more frequent in BD. Regarding weight gain after transplantation,
More frequent with the hemodialysis.
why? Weight gain is more frequent after hemodialysis in comparison to peritoneal dialysis. Why?
No, I don't.
Because in peritoneal dialysis, the patient is subjected to glucose load. And after transplantation, we avoid glucose load. So the tendency of these patients toward less weight gain because we get rid of glucose load that they were accustomed to have. Infections, more frequent in peritoneal dialysis than the hemodialysis. So this is from this paper, but you can find other data in other publications. This is a very interesting study, although it included only 160 patients, because here they do analysis. Here, this pre-transplant dialysis modality doesn't influence short or long-term outcome in kidney transplant recipients. The analysis of paired kidneys from the same deceased donor. So it's cadaveric. So the donor has two kidneys. One kidney go for two patients who are hemodialyzed, and the other for patients who are peritoneally dialyzed. So, and the outcome of both kidneys are the same. So dialysis modality doesn't affect the outcome in this study. As you see, survival either after hemodialysis or peritoneal dialysis is the same, no significant difference. And the graft function is the same after hemodialysis or peritoneal dialysis. Okay, and the kidney source is the same donor. One kidney goes for patients on hemodialysis, and the other goes for patients on peritoneal dialysis. But the only significant difference was the common frequency of lymphocyte in peritoneal dialysis in comparison to hemodialysis. This is a nice article. It is the Association of Pre-transplant dialysis Modality and Post-transplant Outcome, a meta-analysis study, included 6 studies that reported adjusted hazard ratio for 5-year mortality, which included more than 200,000 patients. And the results are in favor of peritoneal dialysis. So either no significant difference, or the here 5-year post-transplant mortality is less with PD, so the data are favoring peritoneal dialysis. Here the 5-year post-transplant graft survival, little bit here. Here the delayed graft function is less common with peritoneal dialysis, so this data, the meta-analysis, is assuring the issue of PD. If I ask you, is it PD or HD before transplantation to recommend based on this data?
HD may be beneficial, but BD is not.
So I discussed all the points from the literature, but at the end, it's very wise to use the available modality. So according to patient preference and according to the feasibility, we go for the any modality. So if we are happy with peritoneal dialysis, fine. If we are happy with hemodialysis and controlling hemodialysis, is fine.
Okay.
This is the wisdom of analysis of the literature. Regarding pre-transplant dialysis duration, here, this is the data of the transplant dialysis duration risk of death. So the first important point, is prolonged dialysis before transplantation risky for patient death? The answer is yes. According to this study, the more the prolonged the dialysis duration, this will affect the survival, as you see in this Kaplan-Meier curve. This is a patient who are dialyzed for less than 1 year, for less than 2 years. Then this is from 36 to 59, and above 60 months, above 5 years. As you see, the more the duration of the dialysis, the less is the survival after transplantation. And this is another study, which is a very recent article addressing the association of kidney transplantation with the survival in patients with long dialysis exposure. This article addresses transplantation after doing dialysis for more than 10 years. So it included more than 5,000 patients who are dialyzed for more than 10 years. Even if the patients are dialyzed for more than 10 years, there is, at the long term here, as you see, there is survival benefit of doing transplantation. The problem is within the short period after transplantation, within the period of surgery, there is some little bit increasing the risk, but on the long run, comparing to the dialysis, doing transplantation is associated with better survival. So in the early, there is increasing risk within the first 180 days, and then the risk will become equal after 600 days, and on the long term, the survival is better if we proceed for transplantation. So even if the patients are dialyzed for more than 10 years and there is a suitable donor and there is no contraindication for transplantation, it's better to proceed for transplantation because the long-term survival is superior. Another interesting data. So here in this sector, we address the issue of survival. The longer the dialysis period, the lower the survival. Okay. Regarding the bladder capacity, If the dialysis duration is prolonged, what will happen in the bladder?
The bladder capacity will decrease.
Will decrease with the time. So this is the disuse atrophy of the bladder. And here, if you look at the data, this is the dialysis duration, and this is the pre-transplant bladder capacity. The longer the dialysis duration, the smaller the capacity of the bladder. But the good news is after transplantation, the bladder resumes its capacity in the majority of cases, but with the expense of reflux. So the more the prolonged the dialysis duration, the lower the capacity of the bladder. Yes, the bladder will regain its capacity, but with the expense of vesico-ureteric reflux. So if we transplant on very small bladder, there is increasing risk of vesico-ureteric reflux that may affect the outcome of transplantation. So here I address the issue of dialysis duration and the survival, then the bladder issues, and now I'm going to shift to malignancy. The prolonged the dialysis duration, the increase, the higher the risk of malignancy. So if you look here, this is the data comparing the time on dialysis before transplantation less than 1.5 years, 1.5 years. This is the reference. And here, if the dialysis duration between 1.5 to 2.5 years, 2.5 to 4.5 years, or above 4.5 years. The unadjusted hazards here and the adjusted hazard there is increased if the dialysis duration is prolonged. So the more the prolonged dialysis duration, the higher the risk of development of cancer post-transplantation. And it seems that dialysis modality doesn't affect this issue. It is the dialysis duration. So dialysis duration, the more the prolonged dialysis duration, the higher the risk of urinary cancer, lung cancer, and other solid organ malignancy. Regarding thyroid, this is a very important cohort because it included 229,000 patients. Cancer thyroid occurred 2.5 higher in transplant recipient, and the most important risk factor is doing dialysis for more than 5 years. So doing the prolonged dialysis is bad for this issue. Regarding preemptive transplantation, preemptive means doing transplantation without preceding dialysis. So dialysis is zero. If the patient has a suitable donor and he is on a stage 5 chronic kidney disease, and I'm thinking to start dialysis, and if he has a donor, we can proceed for transplantation without dialysis for all cases. If there is an exception, this is my question to you.
Yes, maybe.
For whom? Who don't like preemptive transplantation?
For the second transplant?
If there is another group?
No, I don't know.
For patients with active nephrotic or nephritis, is it better to go ahead for transplantation or to do a period of dialysis first?
Period of dialysis.
So for nephrotic patients, for nephrotic syndrome, it's better to start dialysis before transplantation. So for nephrotic syndrome, because we are afraid of hypercoagulability and the activity of the disease and the recurrence of the disease. Regarding the issue of second transplant, because your answer was in second transplantation. In second transplantation, this is a very nice data showing that even for the second transplantation, if the patient has first graft and then he develops graft failure and he has a donor, we can proceed safely and better to proceed safely for the second transplant preemptively, so long as the duration of the graft survival of the first transplant is above 1 year. So if we are dealing with the second transplant, we should ask about the duration, the graft survival. If it is above 1 year, we can proceed directly for preemptive transplantation, because there is some data showing that there is a problem if we proceed for transplantation while the graft survival is less than 1 year. So the issue in the second transplant depends upon the duration of graft survival of the first graft. If it's less than 1 year, yes, we can support the patient by dialysis for a period of time and then to proceed for transplantation later on. But if the patient's if the graft survival is exceeding 1 year, it's better to go ahead for preemptive second transplantation. Is it clear?
Clear.
Okay. Regarding the risk and the benefits of preemptive second transplant, this is the issue that we discussed. Regarding the issue of hypophosphatemia, do you remember the question in the beginning? If we do preemptive transplantation, the preemptive transplantation is associated with little bit lower level of FGF23, because FGF23 increases on CKD and become highly increased on dialysis. So if we go ahead for preemptive transplantation, this means that we transplant on a little bit lower levels of FGF23 in comparison to dialysis. And as you know, FGF23, if it is high, it will lead to more hypophosphatemia after transplantation because it is phosphatotic hormone. And after transplantation, the kidney is functioning, so it can stimulate hypophosphatemia. So one of the advantages of preemptive transplantation to avoid severe hypophosphatemia. So we should tackle the issues of barriers. Here, this is the barriers for transplantation. If we think of race, here, this is a multivariate analysis of variables associated with referral for transplantation before the initiation of dialysis, preemptive transplantation. Here, white persons find their way for transplantation. So the likelihood of doing a preemptive transplantation is higher for white in comparison to black. The referral by transplant nephrologist, if transplant nephrologist is involved, yes, the referral will be higher too. If the patient here not employed, this is a reference, but if the patient is employed, the tendency for preemptive transplantation is higher. And for original kidney disease, here, diabetic, here in diabetic there is tendency to do dialysis. So the preemptive transplantation is less frequent in diabetic. But in polycystic kidney disease, the majority encourage preemptive transplantation. So it seems that there are barriers from the race, from the socioeconomic status, from the original kidney disease. Regarding these special issues, so we should encourage the transplant referral. And one of the job of the doctor, nephrologist doctor within the hemodialysis unit is to know who is suitable for transplantation and to be referred and to discuss with the patient the issue of transplantation, so long as the patient is suitable for this. And this study shows the clinical social networks within the dialysis improves the transplant referral. Regarding eye shoes, do you know what's meant by eye shoes?
I think it's a program.
It is electronic program. On iPad or anything like this. And this is from this university. This is the Emory University, and this is the last modified on August this year. And this is a very fantastic calculator. Here, you put the age. You just click on male or female, click on race, then the ethnicity, and here the duration of dialysis. So the duration of dialysis is important in the calculator. The patient history, including hypertension, yes or no, diabetes, low albumin, cardiovascular disease. You're just clicking. And if you click, if this is an example, if the patient age is 55 years and he's a male, black, non-Hispanic, dialyzed for more than 1 year, and he is diabetic. If these are the data, if you just click, you'll find, if you leave the patient on dialysis, here the mortality is 14%. So among 14 out of 100 people will die in the next year on dialysis. So the 1 year survival, 1 year mortality is 14% on dialysis, but in transplant is 4%. This means that there is survival advantage if we proceed for transplantation. 4% mortality in comparison to 14%. And after 3 years, it's 27% mortality on dialysis and 8% only on transplantation. And this calculator is smart because it gives you idea about the impact of the disease or living donation on survival. Here, living donor transplantation is associated with better survival. So you can play with this data, just change and click, and you know, fantastic data. What is the value of this data?
To predict the outcome.
To predict the outcome of transplantation, and to select, to help the patient to select the proper modality for renal replacement therapy, and it can be used in education of the patient. So it can be used for predicting the outcome and for education the doctors and the patients too. Don't forget that the referral for kidney transplantation is considered one of the quality issues for evaluating the quality within dialysis unit. The more the referral for kidney transplantation, the better the quality surface of the hemodialysis unit. Regarding the issue of original kidney disease, the data of the 700,000 patients from the United States, and the data is very fantastic, because here these are the different causes of renal failure, either glomerulonephritis, primary, IgA, FSGS, membranous, MPGN, or secondary glomerulonephritis, lupus, vasculitis, or non-glomerulonephritis, diabetic nephropathy, and polycystic kidney disease. This color is reflecting the death on dialysis, and this color is the living donor transplantation, and this is cadaveric. You can fix this slide and look at the different original kidney disease. You will find here IgA nephropathy is associated with lower risk of mortality on dialysis and the increasing opportunity to have transplantation, either living or cadaveric, in comparison to other glomerulonephritis. And here, for diabetic patients, the mortality is higher on dialysis. And so you can fix this slide and look at the impact of original kidney disease on the outcome of patients, either mortality on dialysis or proceeding for transplantation. Another important point is when we do dialysis for a patient, we should think of hyperparathyroidism. Because if you leave parathyroid glands without control, this means that very high level of PTH is associated with graft failure. So here, the threshold of PTH that can predict graft failure are the high levels of PTH. So it's better to control PTH for the patients on dialysis. High PTH before transplantation is a predictor for poor graft outcome. And these are the odds ratio, as you see, for graft failure, increased drastically with increasing PTH. Is there any guidelines? This is one of the guidelines stating that for most patients with end-stage renal disease, the guidelines suggest preemptive transplantation rather than waiting until dialysis is initiated. It is, yes, it's a suggestion and based on weak evidence, but this is the guidelines. And for most patients who are receiving their second transplant, after the first transplant kidney has failed within 1 year, there is a suggestion for short period of dialysis prior to transplantation rather than preemptive transplantation. But if the first graft stayed for more than 1 year functioning, it's better to go ahead for preemptive transplantation. Let us to repeat the questions with explanation. Dialysis should be done within 24 hours of renal transplantation as a routine.
False.
False. Why? Because if there is no critical indication for do dialysis, we just keep the patient on his routine dialysis and doing transplantation. It's not necessarily to do dialysis within 24 hours because we are afraid of graft dysfunction and we are afraid of delayed diuresis if we do aggressive dialysis on the day before transplantation. And there is no data showing the superiority of the transplant outcome if we do dialysis within 24 hours of transplantation. Second question, is continuous inhibitor before surgery is recommended?
True.
True or false?
True.
True, because we are afraid of a hypotension with the use of this drug. So, generally speaking, for any surgery, respective to the renal failure or dialysis, for any surgery, if the blood pressure is controlled, it's better to stop its inhibitors or ARBs for at least 1 day before the surgery. But if the systolic blood pressure is very high and it is we cannot stop ACE inhibitor, we should discuss with anesthetist that the patient is on ACE inhibitor to avoid the hypotension on surgery. Prolonged fasting before transplantation is associated with hypoglycemia and hypokalemia. Is it true or false?
False. Hyperkalemia.
Hyperkalemia, because hypoglycemia, yes, I agree with hypoglycemia, and hypoglycemia will switch off insulin that may lead to redistributional hyperkalemia, not hypokalemia. Post-transplant weight gain is more frequent if the patient is on BD program.
False.
False, because
On
hemodialysis, because here we get rid of glucose load, so the tendency for weight gain is less for patients who are maintained on BD. Post-transplantive vesico-ureteric reflux is positively correlated with duration of dialysis.
True.
True, because the more the prolonged dialysis duration, the less the capacity of the bladder and the higher the risk of reflux. Post-transplant thyroid cancer is less common if dialysis duration is more than 5 years.
False. More common.
More common, yes. The preemptive transplantation is associated with more frequent post-transplant hypophosphatemia.
False.
False, because FGF23 is not so elevated, so we are expecting that the risk of hypophosphatemia after preemptive transplantation is less than if transplantation is proceeded after dialysis, because on dialysis FGF23 is higher than preemptive transplantation. Preemptive transplantation after graft failure is associated with less favorable outcome.
False.
It's false, because except
1 year.
Except if the graft fails less than 1 year. So if the graft continues for more than 1 year and then fail, it's better to proceed for preemptive transplantation. iShoes is used for predicting the outcome after transplantation. I think it's true, as I mentioned. So now you get all the statements right answer. So the statement number 2, 5, and 6, and 9 are true, and the other statements are wrong. The last question: when to stop learning?
After our death.
So this is my message. We should continue learning. And this is the way to live. So I am living through learning, and even if I'm teaching, I'm learning through teaching. And this is my advice to all doctors or physicians, to continue learning until the end. Thank you very much for your attention.